Yeah, for our demonstration today, I've failed to find the ECG with proper LVH or RVH or artery enlargement, so I decided to use one of these books. So this is an ECG from a textbook, and whatever it is showing, this is an ECG from a textbook, and this is what it is showing. We are going to confirm whether there is LVH, RVH or artery enlargements by following so far what we have said. If you look at lead 2, that's where we said for artery enlargements. If you look at this is P wave, or identifying them, P wave, Q, R, P, Q, R. That's what we have. In V1, because that's what we said, we have P, this is P wave, and we say it has to be biphasic, P, very small r, and then S, P, very small r, and S. So, do we have artery enlargements? Remember the criteria and the normals we said. If we zoom in on lead 2, this is what we are going to see. This is a large big box. This is a large big box, and the dotted lines inside demarcates the 5 boxes I drew. So if you look at this P upwards, it is 1 millimeter or 1.5 millimeters tall. But if you look at the side of horizontally, this P wave starts from here and it ends from here. So this P is wider than the normal. This P is more than 2.5 millimeters. Here in the middle there are already 2, 1, 2, 3. So it is 3 and above. So it is wider than the normal. So this one, even when you see the shape, this is not the shape of the normal P we said. We said it has to be rounded. But if you fall up on this rhythm strip here, see this P is not rounded, it is notched. This one is notched, notched, notched. This P is very wide, so resembling P mitral left artery enlargement. But let's check what is happening in V1. In V1 we said the first part is the right atrium and it seems normal. Upwards it should be less than 1.5. It is less than 1.5. Then the left atrial component, it should be less than 1 millimeter downwards, but it's more than 1 millimeter. And then if you check, it should be less than 40 milliseconds. That is 1 millimeter wide, less than. But this one seems to be wider. You see, it is even notched. It is broad. P terminal force. It is broad. So this is left atrial enlargement. It is there. So left atrial enlargement. And now let's see ventricular enlargement or hypertrophies. Are they there or not? We are using the criteria. Very small r in V1, very fine. And then slightly tall r in V2, slightly tall r in V3. Then if you go to V4, r becomes very tall. V5, it's very, very tall. And then V6, it reduces. So this is a normal RS progression, but where the problem comes in is the voltages. Remember the voltage we said, like when we use the most common criterion, that is Sokol and Dion, S wave in V1 plus R wave in V6 or V5. So if we check S wave in V1, we said going upwards, one small box is 0.1 millivolts. So 0.1, if we need 10, and one small box is 1 millimeter. So if we take 5, one big box, 2 big box, 3 big box, 4 big box, 5 big box, 5 big box, here there are 3, and then plus 2, 6 big box. So this S in V1, S in V1 is equal to 6 big box, 6 times how many millimeters now? They are 5 millimeters. 5 times 6, that is 30 millimeters. Its wave in V1 in this case it is 30 millimeters. If we go to V6, it is 1 big box, 2 big box, 3 big box, 4 big box, 4.1. So what is 4? So in V6, that is 4 times 5 is 20 plus 4, 24. So R in V6 is 24. When we add them, we shall get 30 plus 24, which is 54 millimeters. Is it above more than 35? Yes, it's more than 35. So this ECG, it is for, it shows LVH and left atrial enlargement. Other criteria we check for the axis. I told you how to look for the axis. I showed you that you look in limb leads, you see in limb leads, and you check, you pick one with the tallest positive complex. Tallest positive complex, that is the easiest. This is 2, 1, AVL. So AVL, lead 1 shows the tallest positive, lead 2, probably around the normal axis. Axis is a bit normal, it's still normal. This one we don't have axis deviation. If we check in AVL, we say it should be less than 11 milliseconds, and it is, yes, it is less than 11 milliseconds, not fulfilled. We check S wave in V3, and then with R wave in AVL, in V3, see where it is, stops this side. This is massive. We need, for males, we need 28. So only from 1, 2, 3, 4, this is 20, 5, 6, 30 here. We already exceeded the limit, confirming LVH. So if we check for the strain pattern, we have said ST depressions and T wave inversions. Then from V3 to V6, it is already there. In V3, this is V3, T wave is inverted. In V4, ST is depressed and T wave is inverted. In V5, the same, ST depression and T wave inversion. In V6, the same. So we confirm that this one is LVH with left atrial enlargement. We can read what they are saying here. They are saying a typical example of LVH. The features are deep S waves in V1 to V3, tall R waves in V4 to V6, STT changes in V5 to V6 called strain pattern, and left atrial enlargement. Some degree of ST elevation is there in V1 to V2. That is very common, and it is proportionality. If you have a very deep S wave, it may affect the ST segment, either to be elevated or depressed, and in this case it will be elevated. So 90% of healthy young men have 1 to 3 millimeters of ST elevation in V1 to V3. That is repolarization. The deeper the S wave, the more the ST segment elevation. That's what I've just said, proportionality. The deeper the S wave, the higher or the taller there will be the ST elevation. If it's for early polarization, it is there very mild and it has a characteristic finding feature. For example, like this one. This is early polarization changes. Note that the QRS axis is not deviated to the left. Is not. That's what I've just said. Here we don't have left axis deviation. Left axis deviation is not part of LVH. In fact, if LED is present, one has to call two diagnoses, LVH and left anterior fascicular block. That's what I've told you. Remember, I wrote like ischemia. Ischemia in LVH, ischemia is there. So if there is ischemia, the vulnerable part of the left bundle branch block is going to be left anterior fascicular block. If there is no fascicular block, then we have that patient may be having a horizontal heart, a very short stature, or obese patient where the heart is horizontal. So there it can produce left axis deviation. Otherwise, it has to be a fascicular block. And the next topic will be conduction defects. So fascicular blocks will come. This is another example. This is another example of LVH. We need to see that one of RVH. These are enlargements. We need to see for RVH. I've said this one, mimicking anterior wall MI, TK. So, let's analyze this ECG at last. First, we have to check if there is right atrial enlargement, left atrial enlargement, or any ventricular enlargement. We start with atria. We check in lead 2 and then lead V1. If we check the P wave in lead 2, it appears normal. We have the rhythm strip of lead 2. P wave appears normal, narrow, and a bit rounded. Doesn't go beyond 2. It is around almost 1.5 millimeter up high, and then horizontally it's also around 1.5. So this is in lead 2. This is a normal looking P wave. If you go in V1, it is predominantly positive, but it doesn't hit the criteria of enlargements because it has to be more than 1.5 high if there is right atrial enlargement. If left atrial enlargement, then it has to be with a negative component, but it's not the case. So this is a normal looking P wave. So in this ECG we confirm no atrial enlargement. According to me, we shall see what they have said in the book as the answer. If we check for the left atrial or the left ventricular hypertrophy or right ventricular hypertrophy, this in V1, we look for that in chest leads. In V1, this is what I said, one of the morphologies I gave. A small Q and then a tall R. If you check this R, we said for the right ventricular hypertrophy, we need that R to be less than 7 millimeters, and this one is almost 10 millimeters. This one is almost 10 millimeters, and not sharp but wider. So it is wider, almost 10 millimeters, is showing non-specific interventricular conduction delay. Like the wider the wave, the slower the impulse conduction, and the longer the time it takes. So this one appears wider and taller. So this is one of the morphologies of right ventricular hypertrophy. If you check in V6, we said persistently tall or deep S waves. If you check this R wave, it is small and narrow, but S wave, it is still there, deep. A normal S wave there should also be less than 40 milliseconds and not deeper than 1 millisecond, 1 millimeter. So this one is deeper to almost 5 millimeters and wider to almost 80 milliseconds. So this is a feature of RVH. If you try to check for the strain pattern RVH, it is there. We say T-wave inversions in V1 to V2. And then this one, unfortunately, it extends. V1, T-wave inversion, V2, T-wave inversion, V3, T-wave inversions, V4, T-wave inversion, V5, T-wave inversion, and then V6, flattening. This patient may be having other abnormalities like ischemia. Otherwise, for RV, it shouldn't be all these inversions. No? Then even inferior leads, they are inverted. This patient may be having ischemia, coronary artery disease. So axis, is it right axis deviation or not? AVL is predominantly negative and the one is also predominantly negative. This one is right axis deviation. This is a right axis deviation. So right axis deviation, and this is the real morphology of right ventricular hypertrophy. What are they saying? The main QRS is deviated to the right. Right axis deviation should make one thing first of RVH. After the right axis deviation, all other diagnostic features of RVH are found in the precordial leads and include tall R wave in V1 and deep S waves in V6. ST changes, they are present, V1 to V3. All these features are present in this tracing. We have said them, we have seen them. T-wave inversion, V1, V2, V3. Deep S waves, V6. Tall R waves, V1. Right axis deviation, predominantly negative, complex in AVL and the lead 1. And the predominantly positive, complex in AVF. And lead 3 has the tallest positive complex. So that is right axis deviation. Yeah. So this is what you have seen in this ECG. Maybe the strategy to interpret an ECG, you have to find the heart rate first. Second one, rhythm first. Then next is heart rate. Rhythm, heart rate, and then look at morphology of the waves. That is axis, and then the morphology of the waves depending on clinical presentation of the patient. So, thank you. Have a good evening.